Urinary tract infections in pregnancy. UTIs are one of the most frequent complications during pregnancy. Traditionally, UTI is classified as either acute cystitis, which means infection involving the lower urinary tract, or acute pyelonephritis involving the upper urinary tract. Then another condition, bacteriuria. This is a predisposing factor or precursor to UTI. And then your patient can have asymptomatic bacteriuria, which means the presence of a positive urine culture in an asymptomatic person, and it occurs in 2 to 7% of all pregnancies. Asymptomatic bacteriuria rates in the pregnant and non-pregnant population are similar. However, bacteriuria during pregnancy, it has a greater tendency to progress to ascending infections because a rapid increase in progesterone level in pregnancy, it will lead to ureteric dilatation and urinary stasis, which increases the risk of bacteriuria. Secondly, mechanical pressure from the gravid uterus and the physiological changes that occur in pregnancy, they further increase the risk of asymptomatic bacteriuria and in turn ascending infection. Asymptomatic bacteriuria is associated with an increased risk of a preterm birth and a low birth weight infant. Treatment of asymptomatic bacteriuria during pregnancy reduces the incidence of both of these complications. Then there are clinical guidelines on management of UTIs in pregnancy. First, we should know about the signs and symptoms, how our patient will present. Patient can be completely asymptomatic, and asymptomatic bacteriuria is symptomless, nothing will be there. Ascending infection, like when the patient is getting pyelonephritis, it may present in pregnancy with low abdominal pain, frequency, dysuria, hematuria, vomiting, or pyrexia. If pyelonephritis has occurred, you will see signs of systemic infection in addition to flank pain. In severe pyelonephritis, there is a significant risk of progression to systemic sepsis, and in some cases, acute respiratory distress can also develop. Untreated pyelonephritis, it may lead to abscess formation and suppuration. Suppuration means that pus will be collected, so that will be a surgical emergency. Then patient can have asymptomatic bacteriuria. Patient can have no UTI, cystitis, and when upper UTI is involved, then your patient can have pyelonephritis. So sometimes it can be completely symptomless. Then frequency will be there, pyrexia can be there, dysuria, loin pain, low-grade fever, dysuria, suprapubic pain, rigors, clinical signs of septic shock. Here we are comparing the low and the upper urinary tract infection. If there is cystitis, your patient will have no clinical signs or symptoms, but frequency, pyrexia, dysuria, loin pain will be there. If your patient has developed pyelonephritis, they can have low-grade fever, dysuria, suprapubic pain, rigors, and clinical signs of septic shock if not treated. Then how we can diagnose on lab testing? Screening for asymptomatic bacteriuria should be performed ideally at 12 to 16 weeks gestation on all women. Some guidelines, they say that between 9 to 17 weeks, so essentially they will cover this 12 to 16 weeks also, the highest incidence of developing UTI. So we have to counsel the patient that she should clean her perineum with water. Tap water is also good, and then she should give us midstream urine specimen. So if we are able to isolate a significant growth of one bacterial species in a clean catch specimen of urine, like we collected after washing the perineum, then it should be sent for urine microscopy and culture. Culture is the gold standard in detection of asymptomatic bacteriuria. However, since the culture can take up to at least 48 hours to obtain a result, then On the basis of suspicion, you can start the treatment. So here also you can take help by doing urine reagent dipstick. So this is cheap, rapid and easy test for asymptomatic bacteriuria, and the sensitivity, you should remember, it ranges between 50 and 90%. So culture is a better result, but since you cannot leave your patient alone even if she has asymptomatic bacteriuria, so just do strip test and then we will see. So culture doesn't have 100% sensitivity, it has 80% sensitivity. So these cultures are helpful in identification of an appropriate antibiotic for treatment. Then sometimes you have to do, in addition to lab testing, you will have to do radiological investigations. Remember, ultrasound is the primary radiological investigation of choice for evaluation of the renal tract in pregnancy. Imaging of the renal tract is indicated when pyelonephritis recurs or it is slow to respond to treatment. And this is to identify renal anomalies or calculi, because both will result in stasis of urine and higher chance of infection. It should also be used in cases where a renal abscess is suspected, hematuria persists or malignancy is suspected, then you are going for radiological investigations. Then we have non-pharmacological measures and antimicrobial prophylaxis. So pyelonephritis may reoccur during pregnancy. So there is some medical evidence that cranberry juice, it decreases the number of UTIs over 12 months. But here the problem is that we don't know that how much juice and how frequently she should take this juice. So just when she is symptomatic, she can take this cranberry juice. Otherwise, we don't have any solid plan to counsel her. So the focus on prevention of recurrence has focused on pharmacological and non-pharmacological measures. The use of nitrofurantoin and a close surveillance policy, it has led to a reduced rate of asymptomatic bacteriuria. Then how we should manage clinically. If your patient has asymptomatic bacteriuria, antibiotic treatment of asymptomatic condition in pregnancy reduces the risk of UTIs, preterm delivery and low birth weight infants. All women, they should be screened for asymptomatic bacteriuria at the first antenatal visit. Treat women with a positive urine culture for bacteriuria detected during pregnancy with an appropriate antibiotic for the bacteria isolated and the trimester of pregnancy. Refer to local national guidelines for the choice of antibiotics in pregnancy. A 7-day course of antibiotic treatment is normally sufficient. So remember that don't prescribe trimethoprim for pregnant women with established folate deficiency or women taking folate antagonists. So if you are giving nitrofurantoin, you should not give it in the 3rd trimester also, because it can cause jaundice in the baby. Second condition can be when your patient has symptomatic bacteriuria. So urine culture is the investigation of choice in symptomatic bacteriuria. Treat symptomatic bacteriuria with an antibiotic in accordance with local guidelines. Take a single sample of urine culture before empiric treatment is started. Women with symptomatic bacteriuria with systemic signs of infection, they should be admitted for IV antibiotics pending the result of culture, pending the results of blood culture and the urine culture. In cases where a clinical improvement fails to occur within 24 hours of starting treatment or where there are additional comorbidities, additional senior medical and microbiology advice should be sought. Renal imaging should be considered if renal pathology is suspected or in cases that reoccur. So what pharmacological management can be offered? You should observe general principles of antimicrobial use, like you have to see that you are selecting the right antimicrobial, and this is an essential part of managing pregnant patient with UTIs. By effectively treating UTIs, it is hoped to reduce the risk of maternal sepsis, pyelonephritis, preterm labor, and also adverse outcomes for the fetus. All acute hospitals, they must have 24 hours access to expert advice from medical microbiologists. or infectious disease physician for the management of infections. In all hospitals, they should have a local or regional antimicrobial prescribing guidelines based where possible on local antimicrobial resistance data. So that's why they're not prescribing just one antibiotic. When your patient has asymptomatic bacteriuria, then antimicrobial treatment is effective in clearing the symptoms of clearing asymptomatic bacteriuria, reducing risk of pyelonephritis, reducing the incidence of low birth weight babies. There have been several trials which have shown that following regimes are effective in treatment of asymptomatic bacteriuria in pregnancy. You can give co-amoxiclav 625 mg TID for 5 days or for 7 days. We can give cefuroxime 250 mg BD or 500 mg BD for 5 days. Then cefaclor 500 mg for 5 to 7 days for women with mild penicillin hypersensitivity. So if she is sensitive to penicillin, you are going to give cefaclor. Phosphomycin 3 grams stat dose can be given. Nitrofurantoin 100 mg BID PO for 7 days. When choosing antimicrobial therapy, it is important to consider issues of teratogenicity and absorption. So if your patient is developing chronic UTI, you will have to give daily suppressive dose of nitrofurantoin, but you should stop at 36 weeks. Don't give it if she's more than 36 weeks into her pregnancy. So if your patient has low UTI in pregnancy, that will be cystitis, infection of the bladder. So how you will manage her? There are limited studies available on treatment of symptomatic low UTIs in pregnancy, and the one study found in our research, it has two regimes which were shown to be equivalent. Either you can give phosphomycin 3 grams stat dose orally, or you can give ceftibuten 400 mg orally for 3 days. For treatment of symptomatic UTIs in pregnancy, it is recommended to treat for 7 days, except in the cases where phosphomycin is used. Phosphomycin, then you are giving stat dose. I repeat, urine culture should be sent a week after the antimicrobial treatment is finished to ensure that the bacteriuria has cleared. Then what are treatment options for asymptomatic bacteriuria or low UTI cystitis in pregnancy? Nitrofurantoin, don't have to remember the doses. Just remember, not suitable to be given after 36 weeks gestation or if delivery is imminent because of the risk of hemolysis in the newborn and subsequent jaundice. This is also not suitable if the patient has renal failure. And don't choose if the patient has a history of glucose 6-phosphate dehydrogenase deficiency, as it will cause hemolysis. So you need to remember this information. This one is not essential. You can give amoxicillin, not suitable in penicillin allergy, not suitable for empirical treatment of UTIs, and should only be used when susceptibility results are available. So this is a good treatment option if your patient has group B streptococcal bacteriuria, as it has better absorption than oral penicillin. So your patient group B streptococcal infection, you are not going to give benzyl penicillin. You will give amoxicillin. This is broad spectrum antibiotic and better absorption during pregnancy, so you are going to get better results. Then you can give phosphomycin. It may be useful for patients with multi-drug resistant organisms. Just remember, if she has extended spectrum beta lactamases, then you will give phosphomycin. It may be useful in patients who are felt not to be likely to comply with a 7-day treatment course because you are giving it stat. Co-amoxiclav or augmentin, this is not suitable in penicillin allergy. Then risk of necrotizing enterocolitis in neonates. So you have to see that delivery is not imminent, and then if patient can tolerate other drugs, then you don't have to give amoxiclav. Cefuroxime, not suitable in severe penicillin allergy, but can be used in mild penicillin allergy according to local guidelines. What is mild allergy? If patient had just mild skin rash. And what is severe allergy? if the patient develop anaphylaxis. And so full-fledged anaphylaxis, it means that patient has significant or severe allergy, so then it should not be given. Then again a question arises that if patient is sensitive to penicillin, what is the chance that she will be sensitive to cefuroxime also? Cefuroxime is second generation cephalexin. So patient will 5% chance that she will be allergic to both penicillin and cefuroxime. So very important to take full history that what was the extent of allergy. Cephalexin, this is not suitable in severe penicillin allergy but can be used in mild penicillin allergy according to local guidelines. So that's all for the lower urinary tract infection. Now your patient can present with upper UTI, which is called pyelonephritis in pregnancy. So there are limited trial data available for the management of antenatal pyelonephritis. So you can give ceftriaxone 1 gram daily until 48 hours. The patient is afebrile, and then you can switch to oral cephalexin. Or you don't have to remember the durations, they will not ask you about that. Or you can give cefazolin 1 gram or 2 gram, and then again you will give and you will continue until patient stays afebrile for 48 hours, and then you can start her on oral antimicrobial therapy in the form of cephalexin first generation cephalosporins. Then you can give ceftriaxone 1 gram intramuscular for 2 doses, then oral cephalexin QID for 10 days. A concern with outpatient management is in the initial stages is that the woman may progress into labor and they should be admitted for at least 48 hours if pyelonephritis is suspected. Because if your patient has pyelonephritis, she can go into renal failure. So that you can understand that that would be a very bad condition because she is pregnant and then she is going into renal failure. So this table is showing the same information, so you don't have to revise it. You can do the table or you can read the notes, whichever works for you. So far we have talked about the treatments. So now can we give some antimicrobial prophylaxis for UTIs in pregnancy? So if this type of prophylaxis should be considered in women in the following groups: pyelonephritis in this pregnancy, known renal structural abnormalities leading to urinary stasis, recurrent urinary tract infections. Then nitrofurantoin can be used for prophylaxis but should be avoided near term, like don't give it beyond 36 weeks or when delivery is imminent because of the risk of neonatal hemolysis. Then you can come across special conditions, situations where you will have to decide for the patients. Like they can give you a patient with renal transplant and then patients with previous reconstructive renal surgeries. Multidisciplinary team should review them. Who should be on the team? Nephrologist, obstetrician, and the transplant team with support from clinical microbiology or infectious diseases consultants as required. For patients who have had previous renal reconstructive surgery, it is important that they have their urine checked regularly and they are managed carefully on a case-by-case basis. Then if your patient has renal stones, renal calculi, these women warrant particular close follow-up as they will have a higher risk for developing recurrent pyelonephritis and sepsis. Then another group of patients who have bacteremia as a result of pyelonephritis. These women may need longer courses of IV antimicrobials depending on their clinical conditions and the state of the fetus. Early switching to per-oral antimicrobials may not be appropriate, and these cases should be discussed between the obstetric team and the local infection specialist because they will need prolonged IV therapy. So that's all you need to know about UTIs. So if your patient has asymptomatic bacteriuria, what do you think? Are you going to treat her or you won't treat her? You are going to treat her because In the second trimester of pregnancy and in the third trimester of pregnancy, the most common cause of hospital admissions is preterm delivery, abdominal pain, and in more than 50% of cases, UTI is implicated. So that's why it's better to treat the UTI, because preterm babies they will have multiple issues, and it is better to treat the underlying cause. Okay, so that's all we had to talk today. We had to talk about today. So now I want you people to complete the maternal medicine quiz and go over the infections, because when we will talk about the infections, the viral infections and the bacterial ones, that they are included in both fetal medicine and maternal medicines. Then tomorrow and the day after tomorrow, I think we don't have a class, but if there is a change in the plan, I'll inform you in advance. So please go over that guideline on perinatal mental health issues and infections, so that we will able to cover that at a faster pace. Okay then, so send me your answers. If you need correct answers, then please send me your answers. Okay then. Yeah, yeah, definitely I will tell you, don't worry about that. Sorry. No problem. Just use that, because it's not necessary that all the answers will be correct. You know, there can be wrong answers. Don't worry about that. Yeah, yeah. Yes, we have to do them. But the more difficult calls we have done, and for the previous ones, we will go over them quickly, because many questions are repeated. So don't worry about them. Even in one session, we will spend like 1 hour only on the recalls, because I will be telling you about the correct answers, and we will not be discussing the topics, because many are just repeated. So that's why. So I think that we should be able to move quickly. Yeah. What else? Yeah. Yes. Yeah. We'll go over them, because last year in 2018 they have added several documents. We'll go over them briefly. Don't worry about that. We'll go over them. Yes, please. Mhm. I think I think I will upload handwritten summary for that. For methadone, just remember one thing, that if your patient was on treatment and she couldn't take that, then you are going to admit her and you are going to give her the methadone exactly in the same manner as she was taking her own drugs. And just one question, they can ask you just one question from there. Mother was on methadone and she has suddenly stopped. So what adverse effect you can see in the fetus? Sudden IUF, nothing else. So don't spend any time on that guideline. Just remember one question from there. That is the point. That's why from you don't have to read each and every guideline, because you have a good background knowledge. Then only the guidelines which they are always including in the exam, we have gone over them. I think most of them we have covered, and you will see on the web page also that many guidelines are already there, simple points, so don't have to read each and everything. So maternal medicine, most of the important topics are done, and others we will do in our next sitting, and that will be a combination of fetal medicine and maternal medicine. Go over this NTD guideline also, and now you have to spend more time because exam is very close. So okay then, I will tell you about the schedule, but tentative that we will be seeing you on Sunday. If there is any change, I'll let you know about that. Okay then, welcome, welcome. Take care. Bye.